than the tube, and we are using it freehand instead of anchoring it to the table with a tube like a tube retractor. So it is a newly developed technique as compared to the transforaminal, and we use a clear continuous fluid irrigation and fluoroscopic guidance. At the lower lumbar levels, transforaminal technique may not be suitable, as we all know. Next. So the advantages are minimal resection of the bone ligaments in the back muscles, preservation of epidural ligaments, reduced complication rates, possible approach of lesions that can be accessed through the transforaminal approach, shorter hospitalization. Next. It is limited in the upper lumbar approach and limitation of decompression for stenosis. We need to use a bigger channel scope, and it is more traumatic as compared to the transforaminal. Next. So all these indications, paramedian, central herniation, sequestered disc, recurrent disc herniation, stenosis, synovial cyst, foraminal herniation, periannular cyst, all these can be tackled. So central herniation, except L5S1, we can't tackle the interlaminar because we need to retract the dura a lot. It is better done transforaminally. Foraminal and far out herniation, again more suitable for the transforaminal technique. And extensive central canal stenosis, we need to use the stenosis scope which has a bigger channel. For Corda-Equina syndrome, although we have now started using endoscopy, but still it is not very popular. And discitis, again, transforaminal approach is more suitable. Next. So as you know, the transforaminal window increases, and that is what we utilize for the interlaminar approach. Next. So we all know this. Next. Let's come to the next. Yeah. So this is how we position the patient. Next. And just we need to mark the interlaminar space in which we need to enter. Next. So this is the insertion of the dilator. Next. Just a stab incision, working port, and then the endoscope in the working channel. Next. So this is most important. When we enter the working sheath, the bevel should be facing the neural elements. And once we have mobilized the neural elements, we can just gently rotate the sleeve and use the tang of this to retract the traversing route. I'll show you how in the video. Next. So this is how it looks like, endoscopic vision. Next. So this is a case, 32-year-old male, pain in the back, severe radiation to the right lower limb, and you can see there's a big disc herniation at the L5S1. Next. So identify the disc space. Next. And then dilator. So first dock the dilator at the facet joint so that you are safe whenever you are docking on the bone. And then we again use this dilator to dissect. Next. And this is the lateral view. Next. Yeah, so this is the video. We need to play the video. So this is how we just identified the level. This is the AP view. And then the sleeve and the dilator inserted. Just a skin incision is taken. Dilator is inserted. And then the working sleeve inserted over the dilator. Then the endoscope is inserted and the ligament flavum is identified. So any muscle overlying can be just burnt off with the RF. So you just clear this muscle because otherwise it's creeping in and then it becomes really irritating. Otherwise you just land directly onto the ligament flavum. You don't need to do any more dissection. Then use a cutter to cut the flavum. Always proceed from medial to lateral. Always from the medial to the lateral because there is a median cleft. And you can see this is how we are opening the ligaments flavum, and you can see the epidural space which has now become visible. You can see the epidural fat through this rent in the ligament flavum. So gradually we will expand this. You can see this. This is the fat, and then as you can see I am proceeding. This is the medial part. This is the lateral. Then proceed from medial to the lateral. This is the cranial part. This is the caudal. And then we just slide in our sleeve, just this much rent is enough. and because of the stretchability of the ligament flavor, our working port just dilates it, and this is clearing of the epidural fat which is covering the neural element. And just a grasper to grasp this epidural fat, and you can see this is the dura which has now started becoming visible, and this is the special RF which we can even use near the dura. And you can see the dura is now started becoming visible there. You can see this is the exiting route, this is the traversing route, and you can very beautifully see this is the axilla traversing and the exiting route. So if needed, we can just expand the level right. We need to dissect it a little more. Then you can, we also have the endocarescence. And you can see beautifully. And then we use a dissector to mobilize the nerve root. And we try to go in from the shoulder, from the axilla. So this is the mobilization of the exiting root. You can see how clearly it is seen. And there you can see the disc bulge there already. And this is the nerve root retractor to retract the nerve root. And then once it is mobilized, we rotate. This is the rotation of the sleeve, and use the tang of the sleeve to retract the nerve root. And then the disc fragment just pops into the view, and if it is required, we can do a small annulectomy with the annulectomy knife. We also have a knife which can go through the scope. So we cut the annulus like we do it in the regular microdiscectomy, and then you can see the disc just pops out. We use the grasper to remove that. So there is absolutely no bony resection is required if you have a big interlaminar window, and you can just directly land onto the target and do the see here. This is a big fragment. Now we will remove it. You can see here, this is how it has been rotated, and the tang is now protecting the exiting route on the medial side. The disc is removed, you can see the disc space has been cleared. And the neural elements are clear. This is the traversing route of the opposite side. Same side, axilla, exiting route, all clearly seen. So even over the top, you can do the decompression of the shoulder. All is completely visualized without doing any bony resection. And as you remove the scope, the tissue is falling back. This is the removed, and just an 8 millimeter incision, and the work is done. Next.